All the indications pointed that direction, but it wasn't until the PET scan was complete that we could be sure.
No more memory tests?
Just the opposite. Mental exercises have shown to be effective.
All right, what is it, 8 years and I'm dead?
Mr. Wachowski, this is not Alzheimer's. For many years, frontotemporal dementia and Alzheimer's were confused. But frontotemporal dementia is a separate disease.
It's better?
FTD is much more aggressive.
Much more. How much more?
Did anyone come with you today?
No.
Family is very important in a situation like this.
I don't have any brothers or sisters, no children. My work is my family. This frontal FTD, is there anything I should be on the lookout for?
You will be subject to overreactions or inappropriate reactions. Blank spells, perhaps you've noticed this already. Mood swings, unreliable sensory perception.
Unreliable sensory perception. That's what it's called.
There are support groups, social services here in Philadelphia, in fact, wherever you go. I've spoken with Dr. Gross, Nathan Gross, in the special care wing. Now, after we're finished, you'll pay him a visit. He's expecting you. There's no reason to be alone in this.
So what is prescribed?
Usually serotonin inhibitors, Zoloft, Paxil, or antidepressants.
But those are drugs for crazy people, manic depressives. You know, that's not me. Okay, let's get that clear. That's not who I am.
These medications address the behavioral symptoms.
Not the disease.
That's correct.
Hello, and welcome to my podcast. My name is Elena, and we will be discussing today the phenomenon of social death in dementia care. I will present you a theoretical framework on the phenomenon, discuss its roots and current tendencies to improve the lives of people with dementia. What you have heard at the beginning of my podcast is a clip from 2014 American psychological thriller Dying of Delight, where the main character, played by Nicolas Cage, is a government agent who loses his memory from frontotemporal dementia. He is a highly decorated veteran CIA agent who is reduced to a desk job because of mood swings, fits of temper, and inappropriate emotional responses that are all symptoms of this type of dementia. In this clip, we witness a very powerful defining moment where the main character hears the diagnosis for the incurable disease. But what is more terrifying, I think, than inevitability of death in this clip is his realization of behavioral and psychological changes that he will be undergoing before his actual physical death. Dementia has been positioned as one of the main global health priorities in the epidemic. This positioning has been accompanied by increased attention from governments, biological and clinical sciences practitioners, care providers, and the wider public. Unfortunately, this increased attention often directed not on the patients but on those who provide care. Dementia is often presented to us as something upsetting and even frightening. Margaret Locke, an American cultural anthropologist, states that Alzheimer's disease and other Alzheimer's-like dementia personify all that is most feared about growing old, a fear widely expressed in research on aging and experience of aging. And I think it's true. The role of media is difficult to underestimate. As sociologist Deborah Lapton in her editorial on health, illness, and media argues, for many lay people, the mass media constitute one of the most important sources of information about health and medicine. Mass media portrayals contribute to the creation or reproduction of knowledge about illness and disease. They work to portray ill people in certain light. And it's true popular media, TV, films, and literature increasingly feeding into cultural understanding of dementia. For example, such British TV series like Wallander or The Missing In Wallander, Kurt Wallander is a sensitive and brilliant detective who is struggling with an early onset of Alzheimer's. In the series The Missing, that also depicts a strong professional man who occupies a senior position, who gradually loses his memory and his mind, increasingly unable to work by attempting to cover it up, and eventually becoming fragile, needy, and very dependent. Some films offer subtle positive messages, such as film Iris, based on a biographical drama about the novelist Iris Murdoch and her relationship with her husband John Bailey. The film presenting us with sharp contrasts which present us Iris and Bailey in the beginning of the relationship, where Iris is still powerful and outgoing woman, and Bailey is a very timid geek. And later at night, when Iris begins to experience symptoms of dementia and devoted John struggles with hopelessness and frustration, he becomes her caregiver, and as Iris deteriorates from Alzheimer's disease. But at the end of the film, we see Bailey and Iris's friends accepting that that she's someone different, with Iris herself happy in the new environment where she's able to be the person she became rather than who she once was. Of course, very difficult to not to mention the film Stis Alice, based on a novel by Lisa Genova, that represents probably the contradictions of the contemporary images of dementia, where on one hand we can feel the fears of obliteration, eradication by the disease, the tragedy of gradual disappearing, while on the other hand we meet the characters who remain, despite the disease, present as a moral force, who still can experience pleasure, pain, and have emotional responses and connection to the social and physical worlds. Sociologist Wendy Martin suggests that film generates certain feelings about dementia, which then become part of our popular understanding and approach to persons living with dementia. Indeed, they potentially become part of how people with dementia come to see themselves, as they draw upon such films as a cultural resource for making sense of their condition. Unfortunately, these are tragic depictions presenting gradual slide to vulnerability, fragility, and becoming as non-person to some people. These representations present dementia as something to be feared, shameful, and as stigmatizing. Many of people diagnosed with dementia realize early on that dementia is not only about physical, but social death as well. I would like you to listen to the second clip that presents us with experience of people after being diagnosed with dementia.
I felt as though I wanted to run away. I wanted to almost die at that point, because it felt to me as though it was going to be the end of my life.
It was frightening because it's not a word, dementia is not a word that you say lightly, and it's not a happy word.
Generally, it isn't well understood. There is still a lot of stigma about a diagnosis of dementia. I think many members of the general public tend to think when someone's diagnosed with dementia, they're immediately at that stage of staring into space. They don't know that it occurs over many years.
I never thought that young people would have dementia. Yeah, but obviously young people do. It was like something very important was taken from me, and it has been.
We don't get as many visitors anymore. You lose a lot of friends and family who don't know how to approach you, don't know whether to say something.
There's that fear factor there for dementia. I'm not sure why that is, and it shouldn't be.
I've got some good friends at the local Warhope Bowling Club. When we first arrived here a little while back, didn't tell them straight away because I was worried about stigma. I wanted to be judged as they first saw me. Dementia is fatal, and if more people realise that, perhaps there wouldn't be as many jokes about it.
I might have trouble with my memory, but there's things that I can do and still have some value, still have some worth, and be part of a community. We can be involved in the community.
Dementia friendly means understanding dementia, that the people know how they can help.
It means being able to tell the people next to you that you've got dementia, and for them to say, oh yeah, no worries Keith, how you going?
To me, it's a place where you feel safe, where people are prepared to wait for you to be slow.
It's, I think, the very small things that people do that can make such a big difference.
The ladies in choir have been absolutely beautiful to me. A group of the ladies put together a great big file for me with the words much larger so that I had a better chance of being able to read the words.
As a volunteer, it's been great because it gives me an opportunity to be out and about again. A lot of it is just weeding gardens for elderly people that are no longer in a situation to do a lot of that work.
My life is still worthwhile. I still have purpose.
I've got no desire to give up or stop. I want to keep living. I want to be part of everything.
We're still people, we still have feelings, we still have emotions, we can still contribute to society.
So, what is social death? The term social death began to appear in the medical thanatological literature in the 1960s. Thanatological, for those who are unfamiliar with the term, the description or study of death and dying, and the psychological mechanisms of dealing with it. Social death as a term has been used by a wide range of scholars from different disciplines working in different fields, so there's no common definition that is used interdisciplinary. It is used by sociologists and historians of slavery and the Holocaust to describe the part played by governmental and social segregation in the process. Basically, social death is a condition of people not accepted as fully human by wider society. Examples of social death are well known as racial and gender exclusion, persecution, slavery, apartheid, governmental exclusion of certain individuals or groups from society, institutionalization, and segregation of those labeled with mental illness or changing the identity of an individual. The term social death first entered social science vocabulary with sociologist David Sudnow in 1967 in his work Passing On, the study of social processes surrounding death. It was based on observation from 2 hospitals where he described how the presumed social value of patients near death determines how they are treated by medical personnel and how much effort is invested into reviving them. He identified the difference between clinical, biological, and social death. Basically, according to him, this is conducted through the actions of others, thereby they treat the person as already deceased, although still clinically and biologically alive. However, a more commonly cited study that implies a distinction between physical and social death is by Barney Glaser, an American sociologist and one of the founders of the grounded theory methodology, and Ansel Strauss, an American sociologist internationally known as a medical sociologist. In their work in 1967 titled Awareness of Dying, they describe how awareness of the person's dying determines social interaction. They build their understanding on social death of Irving Goffman's work titled Stigma, Notes on the Management of Spoiled Identity, where Goffman presented the concept of mortification of self. Basically, mortification of self, according to him, the series of humiliations undermining a person's social identity as observed in mental hospital. According to Goffman, becoming an inmate in a total institution involves a process of mortification of self, means that inmates are subjected to degrading and humiliating treatments designed to remove any trace of individual identity. The idea of social death was introduced to the literature on elderly people by Eric Miller, social anthropologist, and Geraldine Wayne in 1972 in the work A Life Apart, in the context of clinical discussion of residential care. They write, "To lack any actual or potential role that confers a positive social status in the wider society is tantamount to being socially dead. To be admitted to one of these institutions is to enter a kind of limbo in which one has been written off as a member of society, but is not yet physically dead. In these terms, the task society signed, behaviorally though, never verbally, is signed to these institutions is to cater for the socially dead during the interval between social death and physical death. Clinical psychologist Sweeting and gerontologist Gil Hooley in the work Dr. Am I Dead? A Review of Social Death in Modern Societies in 1991 comprehensively reviewed social death literature in sociology and nursing, and later in 1997 in the work Dementia and Phenomenon of Social Death. They identified three major, although overlapping groups of people, possessing characteristics which may lead them to become socially dead in contemporary society. Those groups are people in final stages of the lengthy terminal illness, very old people, and those suffering from loss of their essential personhood. So all these groups are combined in the case of dementia. I would like to use the words of Alan Bennett. He's an author and playwright. He reflected on the death of his aunt, who had dementia and died in the woods by a hospital where she was a patient. She was eventually found only a week later by Bennett himself. Bennett writes, "Auntie Kathleen's life was at its lowest point of social valuation. She was 73, she was senile, she was demented, and she was of no class or economic importance. When she was found, concern centered not on the fate, but on how it reflected on the staff of the hospital and the efficiency of the police work. Even in death, she was of marginal importance as a person." It is heartbreaking. I believe that phenomenon of social death that includes stigma attached to the disease, dehumanization of the patients with dementia, deprivation of their citizenship is a direct result, or we can mildly put it, an undesirable outcome of the continuing dominance of biomedical model that addresses the physiological but neglects psychological and emotional needs of people with dementia. Biomedical model is still a predominant model in long-term care settings. Lack of effective treatment for the disease often replaced with physical, chemical, and environmental restraints that are still widely used for the patient management. Biomedication of dementia is a direct consequence of biomedication of aging, where, according to sociologist Carol Estes, medicine, with its focus on individual organic pathology and interventions, has become a powerful and pervasive force in the definition and treatment of aging. The resulting biomedicalization of aging socially constructs old age as a process of decremental physical decline and places aging under the domain and control of biomedicine. Estes states that the biomedicalization of dementia is clear, and it's reflected in the policies of National Institute on Aging. The commitment to Alzheimer's disease reflects the impressive strength of the disease approach to the field of aging in preference to other approaches that emphasize the basic social, behavioral, and even biological processes. Further, the branching of physiological research into two separate programs has divided what once was a unified social and behavioral sciences program and diminished the funding base of the behavioral and social programs as well. And a significant proportion of psychology research has been biomedicalized as it has been redefined as neuropsychology. This was written in the 90s, but there is still no change. In 2006, a historian, Jesse Belanger, in his book Self, Sentility, and Alzheimer's Disease in Modern America writes that the note of the matter lies in the very character of biomedicine, in its apodictic certainty and its inability to dwell on the unknown. Indeed, the developing field of the dementia research within biomedicine is dense with gray areas that challenge its ability to hold itself together. In 2015, gerontologist Elena Podcast, in her groundbreaking essay Time to Reinvent the Science of Dementia, The Need for Care and Social Integration, states that this struggle within the biomedicine of dementia stems from different perspectives on the nature of dementia, the lack of an effective treatment, and the ambiguous consequences of receiving a diagnosis. Social stigma further complicates the struggle, as individuals diagnosed with dementia are often disempowered, disassociated, and excluded from social networks. The essay provides the insights of an interdisciplinary international workshop entitled Bioethics and the Science of Aging, the Case of Dementia, held in October 2012 at the University of California in Berkeley. Podcast states that to refine its basic orientation, the recent biomedical trend in dementia needs to mature out-of-stage confidence. She suggests that more self-reflective and explicitly ambivalent medicine and aging biomedicine needs to open to other fields and disciplines concerned with dementia, and this reframing can be facilitated through a dialogue between biomedicine and bioethics, public health, social science, and the medical humanities. Podcast identified the main elements of the struggle that is compelling biomedicine to rethink its original orientation. The unsettled definition of dementia comes first, followed by the ambiguous benefits of the diagnosis, the ethical conflict on consent and clinical trials, and finally the need to give more attention to the perspective of the persons with dementia. I would like to concentrate on the third element that Podcast called the elephant in the room. She expressed a recurring concern from many professionals that is for biomedicine to better understand how to accommodate the needs of persons with dementia and how to integrate them within the social network. We still do not exactly what truly matters to the persons with dementia, and our understanding of the lived experience of those with dementia is very limited. Podcast compels the audience to move past the raw medical data, to hear and learn from individuals with dementia, where fears of dementia and consequent isolation are a common lived experience. She writes that the suffering derives from an intangible yet powerful social death. This rupture in biography affects one's sense of self as individuals with dementia endure limitations in their freedom. Preventing these biographical ruptures through reconstruction of a sense of self requires a new attention to the persons with dementia and to the process of self-awareness. In conclusion, I would like to say that I don't want to minimize the impact of dementia on people diagnosed with the disease, the personal professional caregivers. This is a truly debilitating disease that is accompanied by severe behavioral and psychological changes. Over the course of the disease, 80 to 90% of people with dementia will experience severe symptoms such as agitation, aggression, apathy. The symptoms increase caregiver burden, worsen prognosis, and lead to early institutionalization, as well as higher costs of care. Severity of behavioral disturbances accelerate disease progression and is associated with shorter survival time from mild to severe dementia or death. The American Geriatric Society 2012 bears consensus criteria for safe medication use recommended avoiding antipsychotics for treat symptoms unless non-pharmacological options have failed and patient is threat to self or others. Unfortunately, contrary to clinical practice guidelines recommendation, antipsychotics medication are often used as first-line therapy for symptoms management. Use of this medication represents particular concern due to the associated adverse effects, which include sedation, falls, and extrapyramidal signs. Neuroleptic agents emerged as a class of psychotropic drugs with the biggest impact on well-being, social withdrawal, and restrictions of activities in the dementia population. second-generation neuroleptics are associated with a much greater risk of mortality and cerebrovascular events in people with dementia. I think it is time for the biomedical model allow other disciplines to present their views on dementia care. Multiple theoretical works emerging from psychology, nursing, geriatrics, and other disciplines. For example, groundbreaking work psychologist Tom Kitwood on preserving personhood in dementia patients as well as patient-centered care. Kitwood proposed that dementia could be understood as an interplay between neurological impairment and psychosocial factors, for example, health, individual psychology, the environment, with particular emphasis on social context. He believed that the environment has as much effect on the brain as the brain has on person's abilities. Fundamental to Kitwood's theory was a rejection of the standard medical approach to dementia, which focused on rigidly treating a disease. He believed that the basic assumption in the medical science of dementia carried far too negative and predictable implications for the nature of caregiving. Person-centered care, according to Kitwood, in the context of people living with dementia, described as a need to emphasize communication and relationships to maintain a sense of personhood, with a focus on seeing a person. Kitwood explained personhood as a standing or status that is bestowed upon one human being by others in the context of relationships and social being. Another groundbreaking work by Donna Algais and Zizka Cohen-Mansfield suggests that an individual's loss of ability to verbally express their needs and goals can lead them to communicate, express these needs through various behaviors. The presence of both unmet needs or goals, physical, psychological, emotional, social, combined with sensory and cognitive deficits, are hypothesized as being a cause of symptoms of dementia, such as agitation, aggression, apathy. What is encouraging, however, is that some unmet psychological and emotional needs and sensory deficits are potentially modifiable and can be addressed through appropriate psychological and environmental interventions. I would like to finish on a positive note and tell you the story about one of my patients. But there were too many of them, and I honestly didn't know which one to choose because they were all so wonderful. I worked a lot with people in the most advanced stages of dementia. Almost every time when I was going in my therapeutic session with them, I was asked by the staff, why do I bother? They are so advanced they are unable to understand anything. But I still insisted on working with them because of what I learned from them and what they taught me. What I have learned that even the most advanced patients have moments of lucidity when they can see you, talk to you, share their memories. And it's so important that during these moments that become less and less frequent as the disease progresses, that someone is there to be with them, to share these possibly last experiences. They need to see that someone cares and someone understands. That's it for me. Thank you very much.